everybody. Welcome, welcome. While we're still getting some food, I just wanted to kick things off and get rolling. My name's Kevin Costello. I'm the litigation director at the Center for Health Law and Policy Innovation at the law school. Our offices are right across the street on the 4th floor. There are law students in the room, and you're interested in this kind of thing, I invite you to investigate our work a little bit further. We have a whole kind of portfolio of projects that are involved in the social determinants of health. Katie Garfield here is a staff attorney who that is all within her jurisdiction. So if you have questions or if you're interested in working on this in a more professional capacity, talk to Katie and come over and take our clinic and get involved with our work. So today's speaker is Dr. Neal Tyrrell. He's the Inpatient Director of Pediatrics at UMass Memorial Hospital in Worcester, and he's going to take it away from here. Neal.
Awesome. All right, so can people hear me, or is this mic? That mic okay? Good. Oh, good, good. Okay, so thank you so much for having me here today to talk. So I just want to get certain things clear. Coming in, I in no way consider myself an expert in social determinants of health, but more important than that, no one else considers me an expert on social determinants of health. But I do have a fair amount of clinical experience in dealing with children on the front line. I am a pure clinician. I have no dedicated time to research, although in my non-clinical time at an academic medical center, I do spend other time working in quality improvement, patient experience, and patient safety. But pretty much day in, day out, I'm taking care of sick children who get into the hospital. So I'm the inpatient director, but I'm a hospitalist. So a hospitalist, I work in the hospital. I don't have a group of patients that are my own. Kids come into the emergency room. If they're sick enough to be admitted, they get admitted to my service. I take care of them, and then I send them out to their primary care doctor. So this talk really comes out of, in my non-clinical work, I review every complaint, every concern, every medical issue that has come up, every patient who's died in the institution that's happened with a child. All right, so I review every complaint or concern. And then once a month, we have a morbidity and mortality conference. We review the case and we say, what could we as a hospital have done differently to improve the care of this child? In January, I presented a version of this case at that conference, and that there were some overlap in the legal and healthcare realm. So I called Kevin, who's one of my close friends, and I said, hey, could you help me out with this? And would you be able to come and speak at this? So he came out and he spoke at this. And so today, we're going to re-speak about that case with everything's been de-identified. And we're also then going to do a couple of other things. We're going to identify what are the social determinants of health. We're going to look at what is happening, what has happened historically in two major figures, two major studies that have come out that have impacted social determinants of health. And then we're going to look at what we are doing in our current state to impact the health of young people and people in general. So, all right, so this patient history. So we have a 19-year-old boy, newly man, who is coming to the hospital, and it is the end of November. He comes in respiratory distress. He's got a history of diabetes, type 1 diabetes. He comes in respiratory distress. He's really struggling to breathe. He's in near cardiovascular collapse. He's in shock. And he shows up in what is diabetic ketoacidosis, which is the life-threatening complication from diabetes if you're not treated with insulin. He comes in, he is seen to be as sick as he is, brought in by ambulance. He is so sick, in fact, that a decision is made that he's going to be intubated, which is pretty much totally out of the realm of what typically happens with diabetics. So he's incredibly, incredibly ill. He also is in kidney failure because he's so sick. He's unstable. If we go into history, his dietary history is what you would expect of a 19-year-old. He eats terribly. His insulin issues and medication non-compliance, which is medical speak for this kid just is not taking care of himself. But and there's a bit of a negative connotation to that. So he ends up, if we look back in his past medical history, so this is our printout from the hospital of just November. The box is just around November. In November alone, This is his 4th intensive care unit admission for DKA. And each one is pretty much the same. That is, he's in shock, he's in kidney failure, he looks terrible, he gets admitted to the ICU, he gets stabilized, he comes out, a bunch of education is done, and then he gets sent home. Now, of note, there are a few issues in this admission on the 15th. People say, hey, the wheels are off here. We need to really help this kid out in some way. What are you doing to manage your diabetes? The discussion is had with he and his new wife. And to say, hey, he's newly married. And they say, hey, listen, maybe she can help you with managing your diabetes, which turns out to be a terrible idea because she ends up weaponizing his insulin. And that is, she is upset. She ends up not giving him insulin if she's upset with him. He's at work and she's supposed to be driving insulin to his work and she won't do it. There's also concern that she'll overdose him on insulin, which is a real danger. On the 21st, when he was in, one of my colleagues who was discharging him said, listen, please let us help you. Why don't you go to a partial inpatient stay? And he agrees to it. And after he agrees to it, his wife says, you can't leave me. And so he says, all right, I won't go. So in the meantime, he's lost his job because he has been out of work, because he's been in the hospital so much. The other side of things is that his social situation, he is homeless. He and his wife, both, neither of them, their families don't want them living at their house. His major support was his grandmother who had diabetes, and they're just like, we've had it. There also is bad blood between the families. So he's homeless, he is jobless. When I take care of him after this, intubated, we have social work and case management see him. And I say, well, let's get psychiatry involved. On the day that I'm seeing him, I also get a call from his primary care doctor who says, listen, you've got to do something about this kid. You've got to file a 51A. Now, 51A is what I file on children who are being abused and neglected. And I'm like, listen, I can't file a 51A. He's 19 years old now. He can do whatever he wants. And then he says, well, why don't you just have him involuntarily committed? These are words of pediatricians, right? We're not used to people just being able to say we're not going to take insulin if we don't want to. So we call around, we call our legal team, and he's evaluated, and they say he's fully competent. He knows the risks he's taking. So ultimately, they also talk to him about his housing insecurity. And they say, listen, we've applied for Section 8 housing, but there's a bit of a wait of 3 to 5 years. So that's not going to be in place soon. The case manager comes out and says very clearly, this is an unsafe discharge at this time. I run into him a couple of times in between consultants, and when I see him, I am talking to my team of residents and medical students, and I'm saying, listen, we have, every one of us, when we go in, we need to make it very clear that he is going to die, and he needs to know this. So I walk in, and I see him on his way up from a smoke break. He went outside to have a smoke break and come in, and he was drinking a soda with his wife, and I say, listen, you will die. And I document exactly that in my note, and like in the kind of cover your ass kind of medicine, I say, you are going to die if you keep this up. We need to make some changes. He said, listen, I want to go home. And so psychiatry sees him, and they put in their recommendations, which is, hey, he would benefit from housing. That's great. He would benefit from vocational assistance. But there are some barriers there. And he wants to have collaborative discussion. And we cannot involuntarily keep him here just because we think he's going to die. So I discharge him home. And so now the next picture is a representation of this discharge, a visual representation of this discharge. And it is this, all right? It is truly, I cannot recall a more unsafe discharge I've ever been a part of since 2004 when I started clinical medicine. But I feel like I was right behind this tree, like clipping the hedges, you know, shaping things up so it looks real nice as the house burns down. So he leaves, and the next day he comes back in. He comes back into endocrine clinic, And thank goodness he comes back. But while he's in clinic, he has an arrest, cardiac respiratory arrest. He quickly needs CPR. He ends up getting, his heart completely stops working. And he gets a special IV that goes into his bone. He gets epinephrine. He gets 6 minutes of CPR. And wildly, we get his heart back beating, and he goes into the emergency room. I see him in the emergency room, and I think, and I'm crushed. I mean, this is a kid who was running in and outside and I mean, it was like, it was proving everything right. He was going to die. But I thought, all right, 6 minutes down for a 19-year-old, that's not so bad. Hopefully he will recover. And the spoiler alert is this is a terrible story, that he never recovers. In fact, he's on our service for the next 2 months. He has a G-tube put in because he can't feed himself. He has no bowel or bladder retention, so he's in a diaper. He has no meaningful communication. He responds only to painful stimulation. He's like the equivalent of a 2-month-old baby. But at that point, you're not really sure how he's going to progress. I've seen remarkable things with young people. He is currently in the hospital again right now with no improvement. So this is the crux of this case and the crushing impact of this case. Let me take you through a couple of other cases that is what I would describe as standard. All right, and that is standard cases that we're seeing on a regular basis in pediatrics that illustrate points as well. 6-year-old girl who comes in with her 6th asthma admission this winter alone. And also, she has Medicaid. She's in a single parent family. There's loads of difficulties with getting her inhaler, also labeled as medication non-compliant. Next, a 6-month-old baby who comes in with a broken leg and with burns on their arms that have been inflicted by mom's boyfriend. Father's in custody now. Weekly. This is like this. This is what we see on a regular basis. 16-year-old young girl, history of neglect and abuse, who comes in with an overdose and with cuts all up and down her arms. And this is her second overdose. An 8-year-old who comes in with his foster mother, says he's out of control. We need to increase his ADHD medicines. Can we please help? So this is a smattering of what we're seeing in pediatrics. And this, frankly, this is me here. This is me, I mean, and not like in a grandiose way. I just feel like I'm...
Is that actually you?
This is not actually me. But it's like, this is like the medical community being crushed, trying to do things to help patients, but this tsunami of social factors that is overwhelming. So we work at UMass Memorial, and UMass Memorial and Boston Medical Center have a special designation of safety net hospitals in the state. Boston Medical Center takes care of basically the poorest of the poor in Boston, and UMass Memorial, everything west. And we get special funding for that. So we see lots of folks who are really poor. But this really gets into the second. So that's the case. We get into now, what are the social determinants of health? Now, what gets me really excited is that social determinants of health has started to become something that we're hearing about a lot, and we're finding partnership in some odd places. So let's just read this quote. Social determinants of health is an abstract term, but for millions of Americans, it is a very tangible, frightening challenge. How can someone manage diabetes if they're constantly worrying about how they're going to afford their meals each week? Like our patient. This can feel like a frustrating, almost fruitless position for a healthcare provider. That's me. Who understands what is driving the health condition they're trying to treat, who wants to help, but can't simply write a prescription for healthy meals, for a new home, for clean air. And this comes from none other...
Yes.
Shoot, sorry, Kevin. This comes from not Trump himself, actually, but it comes from Alex Azar. This is a Trump appointee, the head of Health and Human Services. When this kind of statement is coming from the Trump administration, you know you're hitting some sort of a paradigm shift. But I'm kind of a glass half full kind of person, because in pediatrics, you can't hardly speak about this administration without people being like, what the heck is happening to our children under this administration? So, so this is exciting. This quote is exciting to me. So AZAR's examples of what are the social determinants of health. So let's shut up. What are the social determinants of health? Things that impact people's health that aren't related to the medication we're giving.
Education.
Education.
Relationships and sense of community.
Excellent, excellent. And that's like probably high, but has been difficult to measure. Yes. General socioeconomic status and things that go into that. And housing instability, food insecurity, domestic violence risk, transportation insecurity, housing, utility instances. I can't pay my electricity. I have to decide between my diabetes Lancets and my utilities, and patient navigation that is helping people coordinate services. All right, so AZAR's example. So where are we in our current state of attacking social determinants of health? So we have basically small scale issues of, hey, I encounter this patient who has an issue, a social determinants of health issue, and he needs housing. So I grab a social worker and I say, hey, can we please help get them housing? Or my wife, who is also a pediatrician, who's sitting over here, who is an outpatient pediatrician, and she sees a patient in this clinic, of which the vast majority of her patients are on Medicare and Medicaid, and they don't have car seats. And they say, hey, we need car seats. And Carolyn says, hey, do you know where you get a car seat? And they say, yes. And she says, are you going to be able to afford car seats? And they say, no. And then I look at my Amazon bill, and there are car seats on our Amazon bill. Not ideal. All right? All right, but this is where the scrounging up of things is happening. All right, so, but so only one step difference than what is happening on that level is little pockets of attacking social determinants of health, like at Montefiore, where they're investing in social determinants of health. And most importantly for healthcare institutions, they're seeing a return on investment of these, especially when you're dealing with pooled resources and not fee for care. Kitty, you want to speak about food as medicine?
Sure. So this is one of our big projects we've been working on over the past 2 years, thinking about the role of food insecurity and malnutrition in health outcomes in the state of Massachusetts. One thing that we've generally found over the years in working in this space, there's sort of pockets of innovation around the state, but there's no sort of systematic approach here to, what exists where, do healthcare providers actually know about it, what is happening in screening for these types of needs, and how does that connect up to broader healthcare reform that's happening in our state? So we do have some movement around social determinants in Massachusetts. But again, there's not this sort of systematic view of what is happening with food insecurity. And so the Food as Medicine State Plan, it did a lot of data collection. So listening sessions around the state, surveys to healthcare providers, insurers, and community-based organizations, trying to figure out what is the need for nutrition interventions. So things like medically tailored meals, produce prescriptions, medically tailored food boxes, things like that. What is the need for that across the state based on chronic illness, food insecurity, transportation needs? What does current access look like? And the answer to that is there's not a lot of access, which is a big hurdle. And then what are the concrete strategies to scale up access to meet the need? And so trying to use the different levers that are out there, either from a policy perspective or just from an institutional perspective, what do we get healthcare providers, clinicians, physicians to do to really make this work, to actually identify the need and address it? And what are the biggest barriers and how do we overcome them? So yeah.
Awesome.
Report comes out next month.
A program that I am super excited about happening at UMass, but I didn't actually even know this program existed until recently because it only started in August. But basically, it is in 3 different areas in the Department of Pediatrics. We're utilizing community health workers. With asthma care, if you live in a certain area, there was a grant to fund a community health worker to go into people's homes. With children who've been taken out of custody of their parents because of abuse, there's a community health worker. And then this program, which is really remarkable, run by this woman in the center, who is it's a combination from Clark University and UMass, and this is Dr. Ross. And she's looking at data sets on who gets arrested. She's finding out that young people who are getting arrested are the same people who have witnessed violence in their growing years. And so she's saying, hey, if you have a history of witnessing violence in the home, then we are going to send a community health worker to your house to decrease stress by helping you access food sources, things like that. Really an excellent program. The other is that insurers are coming about with this and looking at transportation health. That is transportation to and from doctor's visits, but also getting people out into the community and getting to the issue of feeling socially isolated. All right, so here's a quote from two very well-known physicians and that you may recognize. It's been amended a little bit, but the good physician treats the disease. The great physician treats the patient who has the disease. And the even betterer physician treats the societal issues that cause the disease. And this is attributed to Dr. Osler and Cornelius Tyrrell, who's a pediatrician out in Worcester. So I amended the end a little bit. But this is where we're going. So we know that the social determinants are an issue. All right? We think that they are seriously affecting things. And in fact, Deloitte did an analysis of 300 healthcare institutions, said, hey, do you recognize social determinants as a major issue? And 88% of them said, absolutely. We see this as a significant issue, and we're committed to making changes on this. But out of that, 72% of them were not making any investment in social determinants of health. And when they were, they're basically going after hotspots where financial gain is available, which is a fine thing to do if you're putting in their place. But all right, so now let's get one step back and say, well, is there evidence there? I mean, I know that. I am the kind of bleeding heart liberal pediatrician, and so I think, hey, we should be doing these things for our patients. But do they really matter? All right, so now we're going to get into two major things. These are the two major take-home points that I'd like you to take with you. And that is, one is a study that was released in the early 80s by Dr. Marmot in England about basically this guy who's become probably the leading voice in social determinants of health. And then a study on childhood adverse experiences. Okay, so let's go after the first thing. And this is, so this is Dr. Marmot, who is a physician and an epidemiologist who did amazing work he put out a study in 1984 out of the Lancet, right here, that looked at, that was subtitled the Whitehall Study. Whitehall because Whitehall is the description of the British social services. That is, civil servants, sorry. British civil servants. So British civil servants civil services was something that I wasn't aware of this term before. But essentially like everybody who runs the government, right? So everybody who runs the government from the absolute top right under the prime minister to the person who's opening doors and cleaning things up. And everybody in that system has a ranking within the institution and has a financial piece within the institution. And he looks at all of these folks and he says, let's see what their health outcomes are like. Now, the prevailing wisdom at the time in the world of medicine was that the higher you were in the pecking order in a company like the CEO, that would increase your risk for heart disease, right? Oh, that's a super stressful job. You would have increased risk of heart disease. So that's this is late 70s, early 80s. He looks at this and he finds something remarkable and revolutionary, and that is the people at the top, near the prime minister, and the people at the bottom who are cleaning up had a reverse risk of death. So if you were at the highest ranking person, you had the lowest risk of having serious heart disease, and the lowest risk of dying early, and the lowest risk of suicide, and the lowest risk of depression. And if you were in that group who was like all the way through this echelon until you got to the people who were cleaning up, they had the highest risk of dying early. And that is represented by this curve, basically that your risk increases the lower down on the gradient. So he basically takes this and he does remarkable work through two studies looking at this and saying, well, what are the impacts In Whitehall, of all these people, it's 17,000 people he looks at. And this is a continuous gradient. This isn't like a stepwise gradient that people were sicker or getting sicker earlier. But he looks at it and he says, these people all had the same health care. This is England. They have the same health care system. They could all go to the doctor. Why are people getting sick at different rates? These all people have jobs. Why are they getting sick at different rates? So we now move into taking that same analysis, and they start to look in populations in little pockets in cities in London, and they say, well, if that's true at Whitehall, what's the life expectancy in one part of London versus another part of London? And they find that that gradient exists in different neighborhoods. You can be in neighborhoods right next to each other, and you have very different life expectancies. This then starts to take on a life of its own, and this is a couple of maps I'm going to show you of cities in the United States and the life expectancy gradient in those cities in very short distances. These life expectancies are from the UN, looking at that's a later slide. These are life expectancy for a child who is born from 2010 until now. And in my own home city of Chicago, anybody from Chicago? Nice. All right. So, all right, just north of the Loop, right near just north of the Loop, you have a life expectancy of 85 years. Right in the country, we're at about 80 years life expectancy, so a little bit better than average. You take a bike ride down to right near the Museum of Science and Industry into like Hyde Park area, not right near U of C, but in the areas around there, and your life expectancy drops to 69 years. This is a 16-year gap in life expectancy as you take a bike ride down the lake. This is also the same life expectancy for a child who is born into Iraq right now. Next, New Orleans, where it's even more dramatic. You go up near Lake Pontchartrain, and your life expectancy is 80 years. If you're in an impoverished area near the French Quarter, then your life expectancy is 55 years, which is right in line with Somalia. These are American cities with this incredible gradient. So what is causing this gradient? All right. So that's the overall. That's the last thing I'll say about Marmot. But The Health Gap is his most recent book, and it is well worth reading, and I highly recommend it. In fact, Don Berwick at his most recent IHI conference said, "Listen, don't listen to anything I say. Just read Marmot's book, The Health Gap," and I would certainly echo that. All right. So next, we have those social determinants. And now let's look at ACEs. Has anybody in the audience heard of ACEs? Good. All right, so some people. So ACEs, adverse childhood experiences. All right, so this is really remarkable. So this guy here, Vincent Valetti, he publishes this paper 20 years ago, where he basically he's a physician and a preventative medicine specialist, and he's working in San Diego, and he's looking at data sets of looking at obesity trends, and he's asking people questions about them trying to lose weight. He finds, when he's asking questions, that there are groups of people that he's having a very difficult time getting them to follow any direction that he has and have any ability to lose weight. And so he asked one of these women, he says, in his questionnaire, he says, well, I'll start to branch out a little bit. And he says, well, when did you first become sexually active? And this woman says, well, when I was 5 years old. And he said, 5 years old? What are you talking about? He said, yeah, I was raped by my uncle when I was 5 years old. And he said, you were raped by your uncle? And it sends him down this whole path to say, maybe the questions we're asking are all wrong. Maybe we're missing something. Maybe we need to get deeper into what is in these patients' history that is impacting their ability to stay healthy now. So he comes up with a questionnaire that he gives to people who are the Kaiser Permanente system in San Diego. 13,000 adults he asks these questions to. He asks these questions and he says, hey, have you ever been a victim of physical abuse as a child? Were you terrified as a child? Were you ever hit hard enough that it left a mark? Were you ever a victim of sexual abuse? Were you ever neglected and where you didn't have enough food? Were you ever neglected in a way that you felt like nobody cared about you, that nobody loved you? Were your parents divorced? Did you witness your mom being hit? Did one of your parents have a major mental illness? Did your parents have a substance abuse issue? And were one of your parents in prison? Puts out this questionnaire, and he finds, so this is just a representation of this ACEs study, adverse childhood events, and all the questions that he asked. Emotional abuse. I didn't mention emotional abuse, where you screamed at and told you were worthless. He finds something remarkable. This is San Diego people with insurance, all right? And he finds that 30% of those who were questioned said that they were physically abused. 20% of them said that they were sexually abused. So those who work in pediatrics and internal medicine, this is not mind-blowing. Like, this is all around. All right. Now, but the next step. So he found that 2/3 of the people who were questioned had at least one positive score. So everything you said yes to, you get 1 point, and so you can go 0 all the way up. Okay. And he found that 12% of those who were asked ended up having a score of 4 or greater. Now, this is the study that I find the most remarkable study in pediatrics. All right, and just how kind of revolutionary it is in its impact on health. And that is, people would always say, oh, that's terrible. But this slide, actually, it's not really the next slide. This next slide shows, based on your ACEs score, 0, 1, 2, 3, 4, what is your adult incidence of mood disorder? What is your adult incidence of an anxiety disorder, of developing substance abuse, of having impulse control? People said, yeah, that sounds reasonable. This is, really traumatic stuff. You're going to have increased rates of these. Now, but the next slide, the findings on chronic disease was really remarkable. And I think this is where we really see a connection with Marmot's work and this work as a microcosm of Marmot's work. And that is that you look at chronic disease and you find that children, or adults, who when they were children had increasing levels of adverse childhood events, have increasing rates of heart disease, of stroke, of cancer, of COPD, of sexually transmitted diseases. Now, some folks, when they look at this, are like, well, some of this stuff is pretty remarkable, but that doesn't look that dramatic. So it's not like I did this primary work or analysis, but I'll tell you that this difference in heart disease, first off, it's an independent risk factor. It's not like, oh, well, all these folks then went on to use drugs and smoke. These are independent risk factors. And when it's looked at, this risk factor, having an ACEs score of 4 or greater, is a greater risk factor for heart disease than hypertension and diabetes combined. All right. Now, the impact on society. These folks, when they grow up, they have higher levels of missing work. They have higher levels of financial problems and of job problems overall. All right. So, how does this work? Let me maybe come back to, well, all right, so childhood adverse experiences result in the developing brain. It is not just, oh, this is so sad. This has changes that can be measured and tracked in children. When you take adults and you scan their brains, if they have ACE scores of 4 or greater, their amygdala is much larger. Now, for those of you who aren't neuroscientists, the amygdala is like the alarm center in the brain. If I open this door and a tiger came in, your amygdala would turn on and that fight or flight signal would go on and your body would send signals down to the adrenals and you would kick out loads of cortisol and epinephrine and everybody would be running all over the place terrified. Well, when that happens on a daily basis to you when you're young, That's a great response when we're here and a tiger comes in. But when you're young, this has measurable impact on your brain. It leads to the amygdala getting overly large and you cannot turn it off. You are constantly sending stress signals out to the body. You have high levels of cortisol and epinephrine. You have increased levels of pro-inflammatory mediators, and pro-inflammatory mediators lead to heart disease, stroke. You have autoimmune issues because it impacts your immune system, because when you're attacked by a tiger, you're not really interested in fighting off infection because you're not going to live for another 20 minutes. So everything gets put on hold, and you can't fight infections as well. And fighting infections also pairs into finding out cancer cells early and fighting them off, so you have increased cancer. Your behavior, you have poor attachment to people. You cannot parent as well because your connections are difficult. Increased obesity, you name it. All right, all the things we've mentioned. All right, so that is the ACEs study in a nutshell. All right, I'm not going to go more in, although there's a bunch of interesting things to say about physiology, pathophysiology, and the reversal of ACEs, which I have to say, there are ways. This isn't like, oh, hey, we found this problem. People are finding that this can be reversed, but I won't go there right yet. Okay, so we're on the front lines. What are we doing right now? All right, so what are we doing now? We're doing what I just showed you at the beginning. We're showing up for work. We're getting burnt out because we're taking care of patients that we're like clipping the hedges while patients are doing terribly and dying. We're expanding, and these are nothing new to anybody here, but we're expanding our health expenditures based on percentage of GDP. This pink line is the percentage of U.S. health expenditure based on GDP. But when you dive deeper into this, we are investing in healthcare, and the term is used very loosely, healthcare, to the tune of the United States. 16% of GDP is on healthcare, and 9% is on social care. And you look, we're spending not nearly as much on social care as other folks. That is really where we need to be going. So, in my view, we have a simple choice, and it's really about will. Because we have a simple choice of either putting things into place that will support families, housing, food security, support for trauma. And if we don't do these things, we're going to have patients who are going to die earlier. And something I haven't mentioned, but these young people grow up and they're scarred, and they end up, they can't think as well because their frontal cortex turns off. In school, they misbehave and they cannot learn, they can't think. They fail out of school, they become juvenile delinquents, they develop addiction issues, they rob people, they join gangs, and end up in prison. When you look into prison, I can't see a prisoner now and not think that this is a child who is simply a victim of abuse and neglect. And you know why I think that? Because it's true. Because when you run ACEs scores on prison, 96% of prisoners have ACEs scores of 4 or greater. So some people are saying ACEs scores is the largest, most preventable public health crisis in the country, and I would agree with that, and social determinants of health. But like I said, I'm not an expert on this, nor am I an expert in what to do. I'm an expert in seeing patients and treating urinary tract infections. But I find this really worrisome when we go back to my patient at the beginning of this, and I go back and I track his ACEs score, which I wasn't thinking about that day. And actually, let me say one other thing about when I present this case, and I present it at large in the hospital, the internists, the folks who take care of adult patients, they say, Neal, what are you beating yourself up about? What more could you have done? Some people just don't want help. You did everything you could. These aren't people who are heartless. They went into medicine because they wanted to help people. But once you have a different view about social determinants and about trauma, you have a different view about the patient in front of you and what will make a difference. And in my patient, what would make a difference wasn't me educating them about the usefulness of insulin. What is necessary is housing and food and employment and having someone to work with you to get through the trauma of your childhood. Like my patient who, when you dive deeper into it, you find that he has a trauma history of being abused. You find that his mother was depressed and there was addiction issues in the household. And his parents were divorced. ACEs score of 4. He could not hear what I was saying. Everything was trauma to this kid. Kevin, you want to talk about moving forward with, on the larger scale policy front with social determinants?
Yeah, so I just wanted.
Yeah.
I'm a pediatrician as well, and I just happened to be reading The Body Keeps the Score, which is a must if you're going to work in this field. It explains how trauma changes the brain, changes the behavior. And this 19-year-old, you wonder why does he keep going to this girlfriend who's abusing him, essentially. And what happens in the trauma brain is that you choose an environment that you're familiar with more than an environment that's new to you. So for him, being around an abusive girlfriend felt safer than for him to be without her. And that's where I feel like you're spending hundreds of thousands of dollars taking care of him as a person who knows where he's going to be, right?
Yeah.
But you could have just spent $500 on a social worker or somebody who can get down to the treating the trauma of why he's with his girlfriend.
I cannot recommend that book highly enough, though. Written out from a psychiatrist from Harvard, and connected to that, Kevin and I did a calculation of housing cost in Worcester, which is not very much in comparison to his ICU costs. And the expenditure from the state. I mean, first off, it just makes financial sense. You get this kid a house, and you get him somebody who will parent him, essentially. Get a community health worker who will show up on a regular basis. But it's not just providing the things, it's providing that nurturing that is essential. If there's time, I'll mention something else. But Kevin, go ahead, and then any questions?
Yeah, so I'll just go through this super quickly, which is to say, in addition to the kinds of social determinants of health supports that, for example, she'll be being involved in the Food as Medicine State Plan, right? And the Montefiore slide that talks about making sure that their homeless patients have housing vouchers. Those are all super important methods by which the system can meet individual needs of individual patients on social determinants of health problems, okay? If you take a sort of another step back and ask, beyond meeting individual needs of individual patients, what are the more kind of widespread systemic changes that would begin to address this problem? And this is really just a brainstorm to talk about. One of the most important things in this talk was that Deloitte study that showed that only 40% of systems and hospitals that are engaged in social determinants of health work are tracking their results. Well, we all know when it comes to making policy, evidence-based policy has to be built on data, has to be built on analysis of what's happening in the real world. So a systemic solution might be to make sure that every program that's addressed to this issue is doing a good job of information gathering, information analysis, and making sure that data goes to good use. The physician training and accreditation, I think one of the things that Neal said that really struck home is that many of the things that he learned about in terms of in his own hospital system, right? What supports he had, what kinds of resources were available to him, he has only learned by accident. And talking to your colleagues who say you did everything you could, thinking about if we rewound the tape on that physician's training by 20 years and injected social determinants of health issues into the medical school curriculum, it might begin to sort of flatten that, reconcile that difference out a little bit. Instead of just housing voucher, just think about this as the difference between handing out a housing voucher and developing an affordable housing development. That's sort of the difference here. What last point I'll make before we open for questions is, both in North Carolina, is Becca here? Becca's going to go work in North Carolina on Medicaid access issues. Big revolutionary thing. She's a Chilpy alumnus, going to graduate in a couple of weeks.
Awesome job.
The big thing in North Carolina that's happening, and what happened in the form of Massachusetts Accountable Care Organization waiver that they got from CMS, is not just, okay, we're now going to pay attention to social determinants of health, but it's actually taking Medicaid dollars, which is, from a payer perspective, it is a big deal. It's the 900-pound gorilla in the room, to say we're going to take, instead of just saying, yes, social determinants of health are important, North Carolina is now going to actually use Medicaid dollars to fund social determinant outcomes, so that a provider in North Carolina, when they have the 19-year-old in the emergency room, they don't just say goodbye and good luck. They say, here is a prescription for housing, which will be paid for, at least in the last month's security deposit kind of sense, with Medicaid dollars. And that change is a super important one, and it will be a pilot program to see how it turns out.
Can I just make one comment? I think the good news is there is definitely a strong evidence base as to certain interventions. For example, food is medicine, like the idea of medically tailored meals for folks with the 5% of the Medicaid population that consume 40 to 50% of healthcare costs, that it's an immediate cost-saving intervention that works. I think housing, incredible, works. There are things that we can do, and it's great. We now have, Medicaid, Medicare, private insurance system, tens of millions of dollars starting to be invested in social determinants of health. But I guess what I would also just want to point out that I think in this case, maybe if you had been able to connect the person that we're talking about to a social worker for $500, that would have worked. But we also have to understand and accept that there's structural racism, there's institutional racism, there's structural issues based on economics and class, and that really to stop that pipeline, that may not be what the healthcare system can necessarily take on, but we really have to start talking with our government about, so where can the healthcare system stretch? What are the kinds of things we can integrate into, consider like as a medical intervention, like food, like housing, because they are integrally connected. And then what are those structural issues that as a society writ large we really need to start to address to start the pipeline? Because I don't think it's only about let's getting this guy, a therapist, because if he basically goes back to his community, back to his home, back to the structural institutional racism that he faces every day, and I'm not convinced it's going to actually work. So, comment.
Well, I think a little pushback on that. I feel like when you give people agency, it's the first step, right? So we can't change his institutional racism where he lives, but he has agency, and he says, I do live in a place where I'm getting a lot of racism, and there's a lot of unfriendly faces, but if he can learn to reinterpret the faces that he's seeing.
I don't think we disagree.
So,
I just think it's.
I think as a pediatrician, like you can say, well, we got to change the system, we got to have less racial. I think we definitely have to address individual trauma as the basis, because I won't, I'm Latina and I get, racial comments all the time. I'm not going to stop those, but the way I interpret them and understand them does keep me from having an A score. Poor health outcome. But I am in a law school where you guys can change other things that I can't.
Other comments or questions?
I guess I'm kind of curious about the social isolation piece, especially because that seems to be growing, especially in the senior citizen community.
Yeah.
I'll grab a second. I'm curious about what sort of medical interventions happen there.
Yeah. You want to comment on, actually, Dara, Dara's a family medicine doctor. With taking care of older folks, what do you think about that? Let me make one comment with this, but the social isolation, you can't underestimate the impact of that. And I think I might even have, I forget if so this is a slide of basically the mechanistic slide of trauma, right? And so the amygdala, right up here, what I had mentioned, right, that gets triggered, and you basically, first you freeze, right? and a part of the brain says, oh, freeze, just like you're driving along, the rabbit in the road just stops. And you're like, wait, what do I do? It won't see me. That doesn't work, and you move over, and the amygdala sends signal to the hypothalamus all the way down to the adrenals, and you release epinephrine and cortisol, fight and flight, right? And you have all the downstream effects of that. But over here, there is a protective mechanism that is the affiliate response related to oxytocin release. And the worst possible situation is child abuse from a caregiver, because the oxytocin is the response that we have when a tiger comes in, and we all run into that closet, and then we're all together and we're like, oh man, can you believe this is going on? What are we going to do? And it calms the brain down, it calms the body down. Without that affiliate response, trauma cycles out of control, receptors in the brain aren't met, and you just have this continued difficulty with dealing with when I say trauma, but stress and trauma. To me, I mean, don't take care of adults like older folks, but that affiliate response is there with all of us, right? And with children, it's super important. But that alienation is all about that response, the feeling lonely and powerless in that. The affiliate response has a positive impact on inflammatory status in your body. I don't have an answer about mechanistically how we do that for adults, but are there any thoughts about what you're doing with that?
Just, connecting people with community in ways that we can in terms of senior day programs and, of course, ideally, again, institutionally, to create spaces where people can come together and have community would be, fantastic. But it's not something that we have a lot of. And I would also add social isolation in terms of social media and people sitting at home and feeling like, and that's their method of connecting to the world is through screens, that's just such a big part of it, is how we are becoming so much more socially isolated, and so much of it is fostered by the increase in technology surrounding all of us. I mean, every single day I'm seeing children coming into the office and the parent just hands the kid her phone so that she can have a conversation with me and so that the kid is silenced. And then this just becomes this reaction that children have, that they're interacting with screens instead of, heaven forbid, like sitting and actually watching two adults interact and maybe learning about interaction that way.
And I would also highlight from the senior citizen perspective that this is something for all of these services where you have these community-based organizations that are trying to provide them, that are now trying to sort of make the case of how they fit in here and what they're addressing. That is a piece that groups like Meals on Wheels are trying to highlight in some of the studies that they're doing. And when they're trying to connect to the healthcare systems, talking about not just the impact of the food, but the impact of having sort of a person show up at your door, and sometimes even go further than that. I think some groups are exploring, can you sort of integrate sort of a wellness check, a check on, sort of almost like a community health worker role, in addition to providing some of those services. I don't know that we're there yet, but it would be really exciting to see that if we started seeing that connection being made even stronger.
Hi, thank you. That was a very terrific presentation. I used to work in, public health and economic research. And so I was, one thing I was struck by in that research is that there is undoubtedly, as your presentation more than amply demonstrates, a causal link from socioeconomic issues to health outcomes. But I'm wondering where in this framework a possible reverse causal link from health to health issues to socioeconomic issues might figure. For example, if giving a vaccine would prevent an infection that leads to missed school, which leads to poor, say, socioeconomic outcomes, which in turn worsens health outcomes and creates the spiral.
Oh, that's a great point. Any comment, Kevin or Robert? Anybody?
The only thing that I would say, this reminds me of sometimes you start seeing the way that people are picturing these interactions as more of a cycle, right? Rather than an arrow in either direction. You see this a lot when we think about food insecurity and the impact on diabetes, where it's a cycle between food insecurity creates stress, creates poor management of diabetes, and it sort of all reinforces. So that's, I think some people are trying to picture both directions and think about it that way.
And the thing that makes me think of is that cycle is like a rolling cycle generationally. And we're really seeing studies now on the epigenetics of these things, where if you're cared for in a certain way, that you don't have, that it changes how your genes function. So you are unable to care for your children in a certain way, and you have generations of people who are unable to care for their children in certain ways that decrease depression and anxiety. I mean, I just see this ongoing issue of stress, losing your job, poor medication management, not having money, being too stressed to provide the kind of like the holding, the play that kids like, that isn't just a bonus, it's essential, you know? And but the good news is that there's studies showing that fostering that outside of the parent who doesn't have that ability can lead to children who can parent in a different way, who can parent their children in a different way. Like the cycle can be broken.
I just want to make one comment. I think you showed a slide that I loved, which was comparing the United States to other healthcare systems. And what you see is we invest and pay more, a high percentage of GDP than any other country when it comes to medical care. But we do very poorly when it comes to investing in social care. And I think our health outcomes are also terrible, right? The World Health Organization, others rank us very low in terms of our health outcomes. And I think that part of what the social determinant of health investment is really looking at is shifting that to some degree. It's really trying to acknowledge that we could get better return on investment by investing in social determinants of health. That might would help to increase investments there to lower our healthcare costs. And that shows it, because it's not just about, like we hear people talk about, Medicare for all. There's no question healthcare access itself is a social determinant of health and having access to high quality healthcare, but it's going to take more than that. I think was the point really I was trying to make, so I don't disagree that all of those healthcare interventions, therapy, everything makes a difference, but we really have to get at that social investment that we see many other countries doing a far better job of. That's where they're putting their money, and they have far better health outcomes than we do.
Yeah.
Just wonder, have you presented this presentation or a variation of this presentation to audiences that may not necessarily be as receptive, or how convincing? I would imagine that most people here, just given the topic, the fact that they're here within Cambridge, I'm going to make vast assumptions, fall within a certain spectrum politically. So I'm just wondering the extent to which you've interacted with others who may have different feelings or senses, and sharing this kind of data with them, what kind of conversations or dialogues you've had with them.
So the answer is no, because I haven't traveled far enough within this, and we're a fairly insular kind of area in New England. But I will say there's just tremendous power specifically in being a pediatrician, because there's a connection with people there. When you say, oh, this is, when people say, oh, but we're about fairness, and it's not fair to give things to people when they didn't work for them. But people quickly are like, well, for kids, we need to do this for our kids, of course. And so with that avenue, I feel like you have this kind of ace in the hole. Also, I didn't riddle it. Actually, Kevin took out a bunch of pictures of children because he's like, come on, you can't just have all, because you just throw out loads of these pictures of kids who are like the cute kids and the really sad kids, and people are like, wherever you are on the political front, you're like, hey, this is not good for the kids. When it really gets in, the rubber meets the road is when you start talking about adults in prison, and pediatricians see adults in prison as totally emotionally stunted children, right? Who are struggling, and then another side, it's like those are the bad people, But I haven't. The answer, that's a good question.
So our work is in the political sphere, right? So we are working with insurers, legislators to really try to make investment in social determinants of health. And what we're finding is, there's the triple aim of healthcare reforms, right? The idea of improving individual health outcomes, improving population health, and reducing cost. And so the studies on, for example, food as medicine, medically tailored meals, are showing that within 6 months, you have a 16% reduction savings in cost. That's deducting the amount of money that you have to pay for the intervention, still, and there's huge bipartisan support for those kinds of interventions, because frankly, the folks more to the conservative side are focusing primarily on the cost-saving side. And so I think that that's why we're actually making so much progress. As I mentioned, we truly have tens of millions of dollars in investment from insurers that 5 years ago, when we tried to talk to them about this kind of investment, were like, no, we focus on medicine, we focus on healthcare. And now, like, the phone is ringing off the hook of them saying, what are the kinds of investments we should be making? How do we actually get at that triple aim, improve health outcomes of the people that we're insuring or paying for, and reduce costs? So I think that's the bipartisan part of this, is that particularly when it comes to the evidence base growing that shows the meeting of the triple aim, I mean, you really can get a lot of support.
Yeah, absolutely. If you show ROI, that sort of
Right, that's the
overcomes,
bottom line.
it overcomes political objectives,
Yeah, yeah.
and it also sort of reinforces the point about making sure that every intervention is tracked and you build the evidence base, because that's something that overcomes political objections to say whether you agree with this ideologically or not. It simply works from a policy point
So
of
I
view.
guess I would just ask, I agree with this, by the way, I'm just asking, to kind of push us a little bit outside of our bubble. So what I would ask then is someone on your side, somewhere tracking, like, we've had these conversations with these people, we've had these out, they've agreed to this much funding, and now we're gonna track, like, the benefits of that funding, so that the more success you have in sort of demonstrating, like, pick, it's like marketing, right? Like, pick who you're marketing to and pick what stinks to them. So, just like do a gross generalization and say, I'm conservative, all I care about is saving dollars, and that's what you lead with. So I guess I would be curious if there's someone who's also doing that work. It's kind of like the meta-analysis of the impact of your work, if someone's keeping track of that.
Yeah, and I think that really gets to one of the points that Kevin raised, was the need for making sure that the data is good here. And I think while some of the tracking and some of the evidence and these studies are getting better, I think tracking of what's happening in general, what are the size of the problem, and then what are we seeing as sort of health outcomes in response to some of the changes that are happening, in some ways are still lacking. So to give you a sense of this, right now in the ICD-10, so tracking with diagnosis codes, there's these Z codes, but there's the one, for example, for food insecurity doesn't work very well. It's like you lack access to food or water or something. So it's so broad, and it doesn't really target what you're getting at. But there is an effort going on right now to change that. So making sure that things like that happen, so that we can track where this is happening and connect that up to health outcomes, it needs to happen as a first step, I think. So making sure that the data can be captured, and then making sure that people are capturing it in the same way, and that people are actually using those codes, and people are actually responsible for reporting on what happened through things like the Massachusetts flexible services spending, things like that. So yes, I think it's very important, and I think some of the studies are great, but I think you're absolutely right that broader tracking still needs a greater focus right now.
And then I would just like to make the point, just being here among all of you who are hopefully going to go out and do wonderful things to change all of this, that as a primary care provider, I don't get reimbursed when I sit down and talk to a patient
Yes.
about their food insecurity, about the fact that they have a history of trauma in their childhood. I have to code for much more specific things that might be really unrelated to what is actually going to affect change and improve the life of the patient in front of me.
Yes. It's one more unfunded mandate.
There is one simple thing to keep in mind for a lot of the people we're talking about. And again, Neal made a really good point about are they receiving the information or not. Your person obviously does not, for a lot of reasons. There's something called 211. Have they ever heard of 211? So 211 is a number you call. It is the largest human services network in the world. If you've got a problem like I got a child I'm concerned about some other issues. I got a mother who used to go to nursing home. I can't get heat in my house. I can't pay my rent. You call 211. You get a live person, not push 1, push 2, push 3. A live person who will walk you through and ask you, if you can't get heat in your house, do your children have coats or whatever? They will pursue that conversation and connect the person with an agency that will help them solve their problem. It's a really powerful thing. It's a United Way, basically funded thing, public-private partnership, your question, well, I did some lobbying in New York about some of these issues with United Way and also with ACES. To answer your question, is trying to get Governor Cuomo, who we all like him, to actually pay attention to these issues is very, very difficult, even though he would tell you otherwise. So for 2-in-1, to get money, $1.5 million to be part of a pot to make it 24/7, 365, is like asking him to give his first communion money that he got. So it's very difficult to do. So this whole lobbying and changing public policy has to be a lot of grassroots work that's done in connection with people who actually are making the yes. So it's a really important thing.
So thanks for coming, everybody. I think we have to give up the room, but really enjoyed the conversation and look forward to seeing you at Chilby.
Great. Thanks so much.